you know. We are on YouTube now.
Great.
Yeah. So maybe we could start a little bit earlier. Don't you think so? Don't you guys think so?
For me, it's okay.
So I'm gonna make just as people now are on YouTube, I'm going to present all of you to them, okay? We normally have kind of
Sorry, guys. One
no problem.
second.
This is Saturday. We are
Yeah.
with our families. I have my family
I
around too.
I sent away my daughter, so to avoid any
Yeah,
issues.
I'm sending him away right now.
No, no problem, no problem. So I just would like to wish everybody who is watching us good morning. This is the first robotic hepatic surgery symposium from our region here in the south of the country. And for so we have invited some of the most important authorities on this field. As panelists from Minas Gerais, we have invited Dr. Juliano Felix. Welcome, Dr. Juliano. That's a great pleasure for us to have you here today.
Obrigado, João. Thank you, Andrea, for the invitation. It's a pleasure to participate and join to this symposium. It's a very important theme to discuss. And congratulations for your leader as a leader education HPB surgery in South America with your HPB course, annual HPB course. Thank you very much for the invitation.
Thank you. And from Rio de Janeiro, our other panelist, Dr. Thiago Belinha. Welcome and thank you for you too. Thank you. Thank you very much indeed.
Thank you, João. Thank you so much for the invitation. Hope we can add something from our expertise here. And let's see.
Yeah, I'm certain of that. And as our lecturer, Dr. Andrea Cacciaguera from Ancona, Italy. It's a great pleasure to have him here. Fra noi questa mattina. Uh, so, Dr. Cacciaguera, you can start anytime you want. It's a great pleasure having you here and representing the so strong Italian School of Surgery. Thank you again.
Thank you very much, Joao. Good morning to everybody. And firstly, as I said before, congratulations to Joao for organizing all this project, because actually I think it's a great project that will last for, I think, a couple of years, because it's really interesting, especially for young surgeons, this kind of projects. So thank you very much, Joao. So today we are going to talk about technological evolution in liver surgery and what could be the role, what is the role, the robotic role actually. So we are going to discuss the evolution, precision, and robotics that have reshaped liver surgery. So we actually have entered in a phase where anatomy, technology, and surgical strategy are no longer separate concepts. So just a second, I have no conflict of interest to declare. So here is like a structure of my talk today, as my agenda. I will review 4 fundamentals area: the evolution in liver surgery, the history, and the MILS framework with guidelines and modern standards, precision liver surgery, and enabling technologies, and robotic liver surgery, transplantation, and future directions. So when talking about evolution, I'm always starting, even with students, from the past, because the past is where we come from. So actually from Gleason, Rex, Pringle, Coinot. But the modern liver surgery start around 70, 80. But at that time, these historical pillars still support everything we do. Actually, in 1980, with Professor Henry Bismuth, who was one of the pioneers of liver surgery and liver transplantation in France, the surgery was still old if we look back now, because if we look at the mortality at that time was around 30%, even with the smaller resection, 21% wedges, left lobectomy, but with around 30%, above 50% at least of mortality. But right now, after around 40 years, as represented in this paper that we published in 2022, we saw that the morbidity and mortality decrease to around 1 to 4%. It depends, obviously, if you compare open or minimal invasive liver surgery, but even morbidity decrease deeply. Just a second. Okay. So as shown, the modern liver surgery became safer thanks to three domains that evolved together: conceptual factors, technical tools, and among these technical tools, minimal invasive liver surgery, which embodies the synthesis, the synthesis of anatomical understanding, technological progress, and strategic refinement in modern liver surgery. So the objectives of modern liver surgery could be summarized in this picture. This is an interesting article written in 2013, where it's written that the three objectives are actually maximal tumor clearance, maximal liver preservation, and minimal surgical trauma. But before talking about risk assessment, before talking about that, one key question is the resection oncologically justified? Because we have always to start from the oncological point of view. But when talking about risk assessment, the modern liver surgery is driven by the risk prediction and risk prevention. That's why in the last 10 years, various risk model have been published. Like these risk factors, I published a couple of in 2020 about R1 risk factors for resection in open and minimal invasive liver surgery. But even this interesting paper by the group of Professor Aldrighetti, which give not the description only about oncologic outcomes, but it gave a new concept of futile resection. Futile means like when patient has actually an early recurrence. And this is a great example of article because integrate not only the classical statistical method, but also machine learning models. But when talking about, for example, morbidity, bileak liver resection is one of the main liver-related complications. Actually, we are writing and is now under review a great collaboration among 34 centers around the world with a bileak score for an optimal prophylactic drain placement. Actually, still is already online, and for the people who want to use it, can scan this QR code. This is actually very important, not only obviously because of bileak, but for the concept to predict and prevent rather than risk reaction. Obviously, failure to risk is something important, but the prediction and prevention is maybe much more important than that. Regarding post-hepatectomy liver failure, which is still important to predict and prevent, especially in patients with liver impairment, there are now various methods like calculation of liver volume, liver function, even like obviously magnetic resonance, like right now scintigraphy, but many of these methods are still to validate. But a concept I want to point it out is what is the role of minimal invasive liver surgery? Many experiences show that besides the reduced incidence of morbidity in minimal invasive liver surgery compared to open in cirrhotic patient, I want to focus especially on this article written by the group of Professor Troisi, which focus especially on ascites and liver-related complication. Ascites is the most noticeable sign of post-hepatectomy liver failure. And as you can see here in the orange column, minimal invasive surgery tend to reduce this risk. And this brings us to a reduction even in the mortality with an improved survival. If we look at this paper written at the beginning of 2000 with around 1,400 patients with only minor resection with child A patient, the mortality was around 14%. But in this paper we published in 2021, only major liver resection were included with child I patient, but the mortality decreased to 4% actually along these 20 years. So this could be related, as we said, to the minimal invasive approach. And now with the robotic approach, the precision increased deeply. As you can see here, this is a resection or a segment 8 resection we perform in our center. And this article is an interesting article written by the group of Professor Di Benedetto in JAMA Surgery, where actually the post-hepatectomy liver failure tend to decrease while performing minimal invasive liver surgery. So as you can see here, robotic has the possibility to integrate various tools, like obviously intraoperative ultrasound, which is a must in our case, but in most of the center around the world. And with robot, this integration could be integrated even with the 3D tools. As you can see here, we are performing this proceeding, and I want to focus especially on the control of the vessel. Here, obviously, an hepatic vein that have been controlled. I want to specify that in our center we are not using air seal for liver resection. Despite its value support in HPB surgery, around the world is starting to decrease its use due to the high risk of pulmonary embolism. And as you can see here, now we control the Glisonian pedicle for the posterior 8 segment, as you can see here. And then now we finish the resection. But let's skip and let's answer to the question, has become safer? Yes, has become safer liver surgery. And this can be evaluated with the composite measure. For example, textbook outcome. In 2021, we published this paper about textbook outcome, the first time the textbook outcome was applied in liver surgery. And in open and minimal invasive liver surgery, we saw that not only the mortality decrease along these 20 years, but especially with minimal invasive, tend to decrease also complication and specific liver-specific complication like by leak or post-hepatectomy liver failure. Textbook outcome now is a composite measure validated with an international consensus guideline held in 2022. So let's keep to the guidelines actually about minimal invasive liver surgery. But why we need guidelines? At the beginning, only few report cases and few case series have been reported. But after the beginning of 2000, sorry, it's blocked my screen here. Just a second. Okay. After the beginning of 2000, we need guidelines to standardize the minimal invasive approach to evaluate the feasibility and safety. With the first consensus guideline held in Louisville, The first international guideline where defined the indication and limitation and the feasibility and safety. After that, in Morioka in 2014, Morioka introduced control and structure growth in standardized minimal invasive liver surgery with difficulty scoring system and consider minor liver section in laparoscopy as a gold standard. But still, major liver section posterior segment were still innovative. But with the guidelines held in Southampton in 2017, laparoscopy, especially laparoscopy, because at that time robotic liver surgery was still not an expanded tool around the world, laparoscopy was considered a mature and reliable technique, even for major liver section and for posterior segment. But in that case, was reinforced the role of training and the high volume center centralization. After that, we come to Paris in 2023. This is the first consensus entirely dedicated to robotic liver surgery. At that time, was reported that robotic is a major independent platform, not a variant of laparoscopy. And Paris actually marked the formal institutional transition from standard laparoscopy to robotic HPB surgery. And finally, we came to the 2025 with the guidelines held in Brescia by Professor Abouilal, where robotic was integrated into laparoscopic and minimal invasive Mills framework. And actually, Brescia guidelines represent the consolidation of technology-driven and the precision liver surgery, especially for more complex procedures. After that, we have to talk about precision liver surgery and enabling technologies. We know that we start from the Koinot, and Koinot history. Koinot history was the history of anatomy, surgical anatomy for liver surgery, actually. But from that anatomy, in 2000, Brisbane was developed the first classification the first classification for the global nomenclature of liver resection, and it defined each resection based on anatomical boundaries and prevents ambiguity. Without standardized terminology, actually, in my view, precision surgery cannot exist. This classification ensures a common technical languages. After that, we skip to Tokyo guidelines in 2020. With Tokyo guidelines, we got into the era of precision anatomy, because if we speak about Brisbane nomenclature and the Koinot definition of anatomy of the liver, with Koinot, this was the theory, but the reality is completely different. It's a nightmare. And this is what is reported in Tokyo guidelines. In Tokyo guidelines, that unlike Brisbane, which focus on resection nomenclature, Tokyo focus on the functional and anatomical structure of the liver itself, particularly the fine lever segmentation of the portal territories, actually getting to the cone unit based on the Takasaki concept. The Tokyo guidelines is the definition of the portal territories, but in these guidelines was also reported how to safely perform minimal invasive surgery. And in these guidelines was reported the extreme need for tools to follow the proper route, as actually I like to represent the liver surgery has the liver anatomy has the trees in a wood, actually. And this picture, actually, I took this picture from Professor Wakabayashi. So the message is here is the evolution from an anatomical terminology to an operative strategy. But the tool reported in these guidelines that we need for a precision liver surgery was especially intraoperative ultrasound, preoperative 3D simulation, and ICG surgery. But what is reported in this guideline is the synchronism and integration of these three tools that should be used together for achieve a high level of liver surgery. So firstly, let's talk about intraoperative ultrasound, which is an old friend for liver surgery because its first use was reported in 1980 by Professor Makuchi. And is the old yet most irreplaceable tool in liver surgery, even with robotics. Intraoperative ultrasound remained the gold standard for intraoperative navigation to detect deep tumors invisible, for example, to ICG, mapping the biliary anatomy indirectly, identify venous branches during transection, and guiding pedicle isolation. So intraoperative ultrasound is the surgeon ultrasound hand essential for precision. And as you can see here in this paper reported by Ferreira in 2013, its use in the operative room is fundamental because of its high accuracy in terms of sensitivity and specificity, even compared with other tools like CT scan or MRI. But in the laparoscopic era, intraoperative ultrasound became more challenging because of limited dexterity due to difficulty use in laparoscopic liver surgery. So due to restricted probe angles and a steep learning curve of intraoperative ultrasound. But mentors like Professor Ferrero or Professor Torzilli in Italy or Professor Makuchi at the school of Professor Makuchi in Japan led us to use better this technique in expert hands. This is an unforgettable tool. In robotic liver surgery, actually robotic in this case, I think changed the game. It restored the natural ergonomics of intraoperative ultrasound. Because of its stable bimanual control of the probe, precise pressure modulation, 3D magnified visualization of the structures, and easier coordination with the camera and with integration with other tools. Regarding 3D simulation, 3D simulation has become the modern anatomical map because it allows to quantify future liver remnant, identification of portal and hepatic artery variants, understand the venous outflow and inflow, and visualize the tumors and its relationship with vessel. And in the last couple of years, 3D reconstruction has reached levels that cannot be thought before. Actually, as you can see here, there is actually a division, a segmental division, even in the preoperative CT scan. And these, thanks to this 3D reconstruction simulation, we had the possibility to achieve these results and to perform these proceedings that obviously can be performed in expert hands. Like, for example, this proceeding performed by Professor Ferrero in Italy, in Turin, or Professor Torzilli. Professor Ferrero, this was a proceeding described recently about liver tunnel with a tumor in hepatocaval confluence, which was not even considered in the past, or this extreme procedure and difficult procedure called the slice liver hepatectomy, which the 3D reconstruction is fundamental to create cluster of, for example, metastases in order to plan a proper liver resection. Or this procedure, for example, we perform in our center in Ancona with this patient that after a conversion therapy for 23 colorectal liver metastases, we perform a fully laparoscopic ALPS procedure. And this was thanks to obviously 3D reconstruction, but a multimodal management of the patient, integrating also the oncology concept and obviously the technological concept and the technique while performing these complex liver resections. And now let's skip to one of probably my favorite technological developments in minimal invasive liver surgery, because it's a single tool with the unique ability to serve multiple purposes. So its versatility is very wide. But as you can see here, this is the evolution of staining in liver surgery. So we know the staining since 1960, but its evolution start to run only after 2006. And actually, as you remember, in 2006, 2007, we had the first guideline in minimally invasive liver surgery. So the evolution of ICG green goes in parallel with the evolution of minimal invasive liver surgery. But after 20 years, we had the need, the strong need for a standardization even of this technique, with the consensus guideline published about the use, the feasibility and use of ICG green in liver surgery. However, in this paper we published in Annals of Surgery in 2022, we seek to assess the various application, obviously, of ICG surgery, but also concentrating on the dose and timing of administration, which actually is still unknown. Is still unknown because of administration struggling needs to be tailored case by case. There are series, but in the literature, the dose and timing of administration reported are various, not standardized yet, and probably not standardized in the future. The application, as I said, of ICG in liver surgery are various, but the two main applications are obviously tumor detection and liver segmentation. Tumor detection as a pointer on the liver to highlight tumors for superficial lesions, and liver segmentation as a compass to guide the correct transaction plan during anatomical resections. So let's go for tumor detection. As I said, tumor detection, the dose and timing of administration is various in the literature, and is various because especially liver impairment sometimes drive us to false positive, as in this case, in this cirrhotic liver, the administration 2 or 3 days before gave us a lot of false positive, which means that in this case ICG is not useful for guiding our resection. Obviously, ICG has a different pattern for the main liver tumors. Like for ACC, there is a total or partial fluorescence staining pattern. For metastasis, there is a ring fluorescence around the lesion, which are the bile ducts compressed around the lesion that cannot realize ICG through the bile ducts, and cholangiocarcinoma, which has no predominant staining pattern actually. And And right now we have even a randomized controlled trial about ICG in liver surgery. And in this trial reported by the Dutch multi-center study groups, we saw that the use of ICG in liver surgery is fundamental to find even more lesions that cannot be detected, for example, by intraoperative ultrasound or the preoperative images. However, there is something that should be pointed out because what should pointed out, in fact, the visual confirmation could with ICG could be due only on the superficial part of the liver and not deeply. That's why I always recommend to use synchronous intraoperative ultrasound and ICG together, as recommended even by the Tokyo guidelines. Regarding liver segmentation is probably one of the most important application of ICG. I always recommend when administer ICG to giving a lower dose. Actually, I like a cuisine, obviously, but it's like in cuisine. If you give too much salt, you cannot come back. This is the same for ICG in liver surgery. Always start with lower dose to avoid counterstaining to the part you don't want. The most important, obviously, the most used is the negative staining with the higher capability of higher demarcation, especially when performing the extrahepatic Gleasonian approach based on the Takasaki concept. And this is really important, especially with robotic approach. Robotic approach made actually this approach, the extrahepatic approach, easier. And as you can see here, especially for the posterior superior segment or posterior lateral segment, is very useful not only for the demarcation of the transection line on the surface, but for the demarcation along the transection line deeper. This is the difference with a normal ischemic area that you can see here. The positive staining is less used, but it could be used sometimes for single cone unit, but it's very tricky to use. And the dose of administration is very difficult to be tailored. This video is provided by Professor Wakabayashi because actually in our center we do not perform a positive staining. But as you can see here, if you are able to use it, could be useful. And finally, the last two ICG application are for cholangiography, and in this randomized controlled trial can be seen the better visualization of the bile ducts, especially while performing cholecystectomy. For example, we are used to perform even in emergency surgery when in our center are centralized damage of the bile ducts while performing cholecystectomy. We use for the bile leaks, as you can see here, or in living donor liver transplantation, obviously to identify bile ducts. And the last application is like a source of inspiration. A source of inspiration based on this paper published by Professor Ruzzanente of Verona, and is the visualization of the lymphatic drainage, which actually is used right now, is still not the reason for its usage is not known yet, but is brought by other type of surgery, like, for example, gastric surgery or surgery for melanoma. And finally, we go to the core of our presentation, which is the passage from laparoscopy to robotic. So the evolution of robotic liver surgery, and the evolution of robotic liver surgery is a transition, but is a transition based only to one platform because only one platform actually was born in the 2000, and along this year, if we ask to the most of the center which robot you have in your center, probably you will answer this platform. And actually, this is a problem for technology because for technology, the competition is fundamental. That's why right now I'm really actually happy to show this paper because right now we have many platforms. We have multi-arm system, modular system, open console, integrated fluorescence, and system designed for enhanced workspace management. And what should be known is that robotic technology is no longer limited to one platform, but it's a dynamic field evolving rapidly because competition accelerates innovation. So we can see the evolution in terms of operation and publication. Robotic demonstrate clear advantages over open liver surgery, but it's still difficult to report advantages compared to laparoscopy. Still we have many issues regarding the cost because they're still high. However, while robotic surgery is more expensive per case, several trends can reduce the gap. Wide range of instruments are available, for example, that I will talk later, but more competition between platform, reduce operating room time with experience, fewer convention, and higher likelihood of achieving textbook outcome. From the study reported here, great multi-center studies reported by the guided by Professor Goh from Singapore, robotic liver surgery reshaped the boundaries of complexity. Why? Because robotic directly address the limitation of laparoscopy, which was a poor ergonomics in the eye right quadrant, restricted instrument triangulation, awkward needle angles, and, for example, unstable camera control. Looking directly to the advantages of robot compared to laparoscopy, we have dexterity, triangulation, more magnification, suturing precision, ergonomics, stability, and an easier way for teaching. In fact, the modern surgical training is shifting from an apprenticeship-based learning, actually based on your mentor, to metric-based structured learning. Robotic accelerates this transformation because the console environment is standardized with the possibility of simulation, also on biotissue nowadays, and everything can be tracked and standardized. And this is an example of a learning curve in robotic. But what I want always to say to the young surgeon is that you have to develop a new haptic sense based on your eyes. Regarding ergonomics, and this is probably the most important part for the older surgeon right now, but I always say to the younger surgeon that in the future, have an ergonomic platform is better for your back, probably. This gives you less physical strain, less tremor, and less mental load. So actually, by improving ergonomics and stability, robotics help maintaining precision throughout the entire procedure. These are the instruments of robotic, but the drawback of the robotic platform is that you don't have some instrument that you have in lab, for example, the ultrasonic aspirator. That's why we adapt our method coming back to the past. For example, one of the most using technique is the double bipolar crash clamp technique. Actually is based on the cheliclesia, which was something used in the past. So And actually, with this technique, actually we achieve the same outcome that we reach in lab with CUSA. But probably with CUSA we will overcome the laparoscopic way of operating. As I said before, the air seal. The air seal is certainly a useful tool, especially for maintaining a stable pneumoperitoneum. But Japan, for example, has issued an official warning, and the same concern was retained in the Paris Robotic Consensus Guidelines. This for the significant risk of severe gas embolism, particularly when the hepatic veins are exposed or injured. Obviously, robotic platform is the future is fundamental because of its integrated way of way of integrating tools. For example, the integration of ICG, intraoperative ultrasound, 3D reconstruction, and augmented reality, which reduce the workflow disruption and make the possibility for an instant comparison between multiple modalities. As you can see here, this actually will be the future. We are still working on it. I always say to many surgeons to not rely to these future articles too much because we are still working on that. This will be the future for sure, but we are still a little bit far away from this future. This is an experimental surgery. But we are on the road to get there. Finally, the most important part of robotic for sure is the complex procedure with vascular or biliary reconstruction. Actually, in my view, we got the main point here because in laparoscopy we had limited wrist rotation, a stable needle control, and poor ergonomics for fine suturing. But with robotic, we change our mind with an excellent needle alignment, a stable wristed movement, magnified 3D view, which make us able to perform these procedures and achieving these results in such complex procedure, for example, in perihilar cholangiocarcinoma. And finally, the transplantation world. The first use of robotic in the context of liver transplantation is obviously in robotic donor hepatectomy. Obviously, I cannot avoid to citate Professor Breuring from Riyadh, which is the biggest centers in terms of volume, which is now performing almost 100% of donor hepatectomy with the robotic platform, and we are talking about 300 procedures a year. Obviously, the future, because we are still talking about the future, but the future is now almost actuality. Because if we spoke in 2020, was published this article, Dream or Reality, Minimal Invasive Liver Transplantation. After only 3-4 years, we answer to this question. Actually, it's reality for many centers, obviously expert centers. In fact, there are already case series, for example, from our colleague from Modena, Professor Di Benedetto, who published together with Professor Hugo Pinto Marquez this first article with the 4 cases, but actually right now they told me that they will publish biggest case series in Modena. They overcome 25 cases with robotic liver transplantation. Obviously, the selection of the cases is fundamental. And probably this will become in the future the standard of care, especially for the transplant oncology. And for these kind of cases of cirrhotic patient with high level of portal hypertension, probably this open surgery will remain the standard of care. So just to answer to the question we did at the beginning, what could be the role of robotic liver surgery? We have explored the prediction, the precision, minimal invasive surgery, robotic, and even liver transplantation. So to summarize, our answer is that today liver surgery has evolved because of anatomy, technology, and surgical planning. Minimal invasive liver surgery is not just a smaller incision, it's a safer surgery. Is a safer surgery. And precision liver surgery integrates 3D simulation, intraoperative ultrasound, and ICG and anatomical knowledge. And finally, robotic expand the boundaries of minimally invasive surgery into complex territory, the hilum, the posterior segments, and even transplantation. The future will be defined by integration of all these systems, navigation, augmented reality, multimodal imaging. We are not only improving techniques, we are redesigning the entire philosophy of liver surgery. So thank you very much.
Thank you, Professor Cachaguera. Would you mind just stopping your presentation so that we
Yeah,
can
sorry.
see everybody on screen?
Yes.
Okay, thank you very much. Great. Before the question, just would like to thank you very much and make some comments. I have watched different presentation about these robotic hepatic surgery. And what called my attention about yours presentation is that you made a full revision from the past, and because normally presentation about these team is mostly a lot of videos, a lot of surgeries and stuff like that, and you placed the young surgeon or whoever in a progression in history, and you gave all the background about the tools and stuff. And so I did like the way that you presented because it was fine, more interesting than the ones that only videos and videos, because
Yeah.
surgeons tend to like videos, it's true, but it's not it's not enough only the videos when you don't have all the other background that you have just given to us in your presentation. So thank you very much, and congratulations for such a
Thank you very much.
such a rich presentation as you had with so much background.
Thank you very much.
So thank you very much indeed.
The videos are big issues for surgeons, for all the surgeons.
Yeah, we
They
love
want
the
always
videos.
to show themselves, but actually I think the video should be shown when you bring a concept.
Yeah, I do like the videos, not that. But I like to, all the information that you have about the ECG, all the tools that you offer in the progression a long time. So from where it started, where we are now, with all this background, this is very important, I think, for any surgeon, for the advanced one, for the initial one. So I did like your presentation. Thank you very much. And then I'm
Thank you very
gonna
much.
leave the time for the panelists to make their arguments on your presentation too. Thank you. Dr. Bellinha, Dr. Felix, up to you.
Continuing to continue your thoughts. It's very interesting that when we started video laparoscopy, we could not imagine where we would be today. When we say that some things are not feasible, it's because we don't have the technology. So when we say we can't do this by robotic surgery or video laparoscopy surgery, I think that we just don't have enough technology nowadays. So if you told people back in the 90s that we would be doing liver transplants in robotic surgery, So they would say you're absolutely crazy. So I think this presentation shows very well the progress. And when we start back doing only ultrasound, and now we're doing visual laparoscope, robotic, and in the future probably integration of the tools that I think would start to bring us much more probabilities in robotic and visual laparoscopy surgery. So very good presentation. Congratulations.
Thank you very much, Thiago. Actually, as you said, you pointed out because before doing my fellowship in minimal invasive liver surgery in 2019, I got there when I got in Southampton with Professor Abu Hilal, and passing from a transplantation concept, which was only open surgery, only minor recession in lap, I said, how it's possible to perform this kind of procedure? But right now, being in this world for several years, I don't know, for me it's something automatic that the evolution is going on. But it's not like this. If you're going to the past, as you said, in the 90s, and we would say to those surgeons, you will perform a transplantation by robot, or you will perform this kind of procedure, especially in cirrhotic patient, which is something that I always point out, because probably cirrhotic patient is the main application of minimal invasive surgery. Is completely a change of mind right now. But if you talk to the past surgeon, for sure they would say to you, you are crazy. And that's what the first pioneer, when they were used to go to the Congress, other surgeons were telling to them, you are crazy, you cannot do these kind of things. This is not possible to perform this procedure. You have to stop immediately. This is what Pioneer told me about the first congresses in minimal invasive. And but if you think now is something completely strange. But it's always like this. Is the evolution of technology.
Yeah, every major breakthrough of technology has someone said that the person who is developing the technology is a bit crazy. So we have to push barriers. So that's the way we can do progress in technology. In medicine, healthcare, HPB, and every surgery is like that. You have to sometimes to push through something that is you're struggling, but maybe you don't have the technology necessary to do that. So probably in the future we're gonna have newer technology, newer platforms, and probably much more possibilities than we can even imagine today. Imagine in 50 years, we're gonna save your presentation for 50 years from now on. It's gonna be something.
Old.
How could you do liver surgery like that? They won't believe.
Yeah, absolutely. Well, actually, I want to only say something because probably we are reaching a peak of the evolution right now. The curve is going to be more stable for the evolution. Is like happened for the smartphone, for computers, for everything. But I want to say that minimal invasive surgery, laparoscopy, and robotic is only, we have to keep in mind that is only a tool. Open liver surgery is still fundamental, especially if you look at results, for example, brought by many papers about pancreatic duodenectomy. It's really difficult to say that robot and lap is better than open. It's really difficult to bring evidence on that. Probably because the access, obviously, the minimal invasive access in the most difficult and complex procedure tend to reduce the advantages of lap, obviously. But if you select the patient in a proper way, those patients that should undergo open surgery, lap or robot, that will be the perfect way to go through the present to the future.
Juliano?
Yes, I'd like to thank you for the brilliant presentation, Dr. Andrea. And we know that Italy has been developing great work in hepatobiliary surgery. There are a lot of hepatobiliary surgeons, as Fabrizio Benedetto, Guido Torzilli, Andrea. And I think that this presentation answered a lot of questions. We had some in robotic and minimally invasive surgery. I think that open surgery and minimally invasive surgery, there are space for both, but we keep in mind the future is the minimally invasive surgery, the robot surgery. We didn't perform in our service a lot of our major hepatectomies in laparoscope because the difficulty in the tools as a intraoperative ultrasound, but robotic changed the game for us. We had now ICG green and intraoperative ultrasound, and we perform now some major hepatectomies. So I think we have to keep in mind open surgery in cirrhotic scenarios. I think the robotic and laparoscopic surgery it's better. Thank you very much.
Thank you to you, Giuliano. You said something really interesting. Firstly, don't compare me that I'm a young surgeon to those pioneers like Professor Benedetto, Professor Torzilli, Professor Aldrighetti, my Professor Vivarelli are another concept right now. We are the future. We have to paint the future, okay? But what you said about laparoscopy, that you pass from open to robot, or obviously the passage from open to robot is now the main way for the open surgeon to get into the minimal invasiveness. But there is, for example, an article just published by Francesca Ratti from San Raffaele from Milan, that the advantages of having a laparoscopic background while performing a robotic approach. Because obviously, robot is like the movement of robotic surgery is more similar to the open surgery. But all the minimal invasive concepts brought from laparoscopy, like the management of the camera, because if you pass from open to robot, you need to adapt yourself that you are the one who manage your camera. You cannot say, let me see, okay? This is the difference. And all the minimal invasive concept, like to avoid oozing, to obscure the field, are small concepts brought by the experience in laparoscopy that probably give you a lot of advantages when going into the robotic world. Obviously, passing from open to robot is a way, but I always recommend to the young surgeon, to my trainees, to concentrate on the laparoscopic field. In the future, obviously, you will have your robotic space.
I have one question too about the ICG use, because normally most of the time we see ICG use just to like demarcation of ischemic area, but you show that sometimes you also use to help to find new tumors that were not seen in MRI or whatever. So, but you also show that sometimes you can have fake results. So how do you use it in your day-to-day use? I mean, especially for trying to find metastasis or cholangiocarcinoma or another kind of tumors.
So it's very difficult actually say how. For example, the proceeding I described about that patient, we did a fully laparoscopic ALPS. In the first stage, we did 9 wedge resection for colorectal liver mets. In the preoperative CT scan were reported only 5 lesions. Other 4 lesions were seen in intraoperative with ICG green because they were underneath the surface, underneath the surface. That's why ICG is important, but how you said, how you can differentiate from the false positive. So if you have a colorectal liver met, you have a typical pattern, a ring, which is completely different, for example, from the bile lakes that you have not round. Bile lakes are more similar to a lake than a round lesion with a ring, for example. You have to think to keep in mind this, and also, as I said for robot, you have to adapt yourself to develop a new sense, haptic sense, because with your, for example, graspers or something in lap, which is more easier in this way, you can feel the lesion underneath the surface sometimes.
Yeah.
Because obviously the intraoperative ultrasound in that case is not so easy. Obviously, if you are with a small lesion, millimeter lesion in doubt, you resect in that case because it's not so complicated. It depends, obviously, the position, but you resect. But after using for a lot of time ICG, you develop an experience on that. Unfortunately, as I said before, standardization of ICG is very complicated because of the variety of the livers, the functions, the biliary excretions. So it's very difficult.
Yeah, I can see. Yeah. Does anybody have any other question or any comment? Well, we try to keep it about 1 hour, so we got to that. So just like to thank everybody very much indeed. It was a successful presentation, successful questionings. And thank you very much indeed. It was an awesome presentation. We have it recorded in our channel, so I'm gonna send you all afterwards so that we can keep it and spread it, because it's very important, this sort of knowledge to be spread. Dr. Cacciaguera, thank you very much, and hope to meet you in Italy. As I told you before, I go to Italy every
Thank you
6
very
months.
much. You are more than welcome to come to my center to meet my Professor Vivarelli. In our liver transplant center, we will happy to have you there. Really.
Thank you. Thank you to
So,
Dr.
and
Delinha
even
and
you,
Felix.
Tiago, and you, Giuliano, if you want, you are more than welcome to come to Italy.
Oh, it
Thank
was a
you so
pleasure.
much.
You
Thank
guys,
you.
and have a nice Saturday. Bye-bye.
You
Thank you.
too. Bye bye. Bye
You
bye,
too.
Ciao. Bye
Bye bye.
everybody.
Bye-bye. Thank
Thank you
you.
very much.